Okay, so thank you again all for coming to my final individual CE presentation. Today I will be presenting on No Brain, No Gain, treating neurocysticercosis. Okay, I have no disclosures. And I would like to acknowledge Michael, Amanda Caesar, and Dr. Go for their help in making this presentation. Our objectives for today will be to recognize neurocysticercosis in regards to pathophysiology, epidemiology, prognosis, and risk factors, be able to memorize main therapeutic options for its management, also be able to distinguish in different locations of various cysts that will drive our treatment recommendations, identify adverse events and monitoring requirements that are used for medications that are used in treatment, and then at the very end, be able to take all of this and accurately assess a clinical patient presentation to employ a really individualized therapeutic plan for treatment. To start off, though, I did want to show everyone this patient case. So we have a 48-year-old male who presented to Stony Brook when I was on my infectious disease rotation. His chief complaint was dizziness with a subsequent fall and head trauma. He had generalized headache and room spinning sensation. When we looked at his history, we found that in the 1970s, he was born in Honduras. In 2010, he moved to United States. And in 2018, he actually was admitted to Stony Brook with a very similar presentation, but left AMA. And then in 2021, he is now readmitted with the chief complaint I presented. Now, zooming in, as you can see on the left-hand side, this MRI scan, when we're looking at this, we can see that there are 3 big cysts there in the circles. Now, just out of curiosity, and this is where your phones will come into play. Can anyone guess what you think might have caused this MRI imaging? So if you open your mobile phones, you should be able to answer this live time, and please let me know if you are not able to. But do you think this is a malignancy, a bacteria, a parasite, or maybe this is already too much and you don't want to know? Awesome. So I see we're getting some answers. So the answer here is actually a parasite that caused this. And this patient was actually diagnosed with neurocysticercosis. Now you might be wondering, what does that even mean? And that's a great question. So there's neurocysticercosis and cysticercosis. Cysticercosis is an infection with the larval form of Tinea solium or pork tapeworm. And when the cysticerci or the larva of the tapeworm attach in the central nervous system, that's when patients would be diagnosed with neurocysticercosis. A little bit more about Tinea solium. So humans are the definitive host of Tinea solium, or again, the pork tapeworm. Tapeworm ova or eggs can be passed into human feces, where the eggs can survive 2 days or even months in the environment. Pigs are actually the intermediate hosts of Tinea solium, where they can acquire the infection through ingesting vegetation that has been contaminated with those microscopic eggs. Once they are within the pig, they will develop in the intestines, and then they can actually migrate to the muscles of the pig, where larvae will start to develop. So this kind of brings it to question 4 and talking about in the beginning, how do we think that this is maybe transmitted to humans in the first place? Do you think humans contract Tinea solium through undercooked pork, maybe eating undercooked beef? Is it through aerosolized particles from those microscopic eggs that again can live in the environment up to months, or is it none of the above? Okay, so we have a few answers here saying undercooked pork. Now, given your answer to this question, I have a true or false. So true or false, an NCC, or again, neurocysticercosis infection is acquired through ingestion of undercooked or raw pork. True or false? Awesome. So I see some people said true. Now, keeping this in mind, I wanted to present a journal from the New England Journal in the 1990s, where they found 4 unrelated persons in an Orthodox Jewish community in New York City who were diagnosed with Tinea solium and ultimately diagnosed with neurocysticercosis. The question at hand here is that none of these patients had eaten pork, and only 1 patient traveled to a country where Tinea solium is endemic. So that kind of begs the question at how did this happen if we think it's transmitted through ingestion of undercooked or raw pork that is infected with Tinea solium? And this can be explained when we think and look more at the transmission and life cycle. So there are two main infections to consider when we're thinking about the transition and life cycle of Taeniasolium, one being teniasis and second being cysticercosis. Like we talked about on previous slides, when a pig ingests those microscopic eggs from the tapeworm, the larva can hatch and spread into the pig's muscles. Then when humans ingest that undercooked or raw pork that's infected, this is when we would develop something called teniasis, meaning we would have an adult tapeworm. Persons with teniasis are usually asymptomatic, but they can have symptoms that start approximately 8 weeks after ingesting the meat containing the cysticerci or larva. And some of these symptoms might be things like diarrhea, abdominal pain, and weight loss. If teniasis is not treated, generally speaking, the Taeniasolium tapeworms will persist for 2 to 3 years. The second infection is the cysticercosis or NCC. And this specifically is an infection caused by ingestion of those eggs shed into the feces of a human tapeworm carrier. Something to note is these eggs are immediately infectious, meaning they do not require a developmental period outside of the host. Therefore, humans are usually, when exposed to this, when they ingest the eggs that have been contaminated with the food or water, or through person-to-person spread via the fecal oral route. So kind of to pull this all together, teniasis, that is when we would get an infection through ingestion of undercooked or raw pork that has been infected with Taeniasolium. And then cysticercosis or NCC, which we're spending today talking about, we get that through fecal oral contamination or contaminated food or water. Thus, cysticercosis or NCC can occur in communities and regions even if they do not ingest pork nor share an environment with pigs. Also, this means that the infected pork does not contain the eggs that cause cysticercosis or NCC, and having teniasis does not automatically mean also having cysticercosis or NCC. So now, given that, let's revisit the initial question. How is an NCC infection acquired? Is it through fecal oral routes, eating undercooked pork, undercooked beef, or maybe you still have no idea? And if you do not, I would be happy to go over this again. Awesome. So exactly. Contraction through fecal oral route. Now on this next page, this is more of just a Jeopardy question. Where do you think Taeniasolium is most common? And you should be able to, on your phone, select multiple areas on this map, and it'll give us a little pop-up of where you might think this is most common. Great. Yeah, so these are all great locations, and some of these are true. So cysticercosis is actually mostly commonly seen in endemic regions like Central and South America, Sub-Saharan Africa, and Asia, including Southeast Asia, China, as well as India, where pigs are raised in close contact with humans and sanitation is generally considered poor. So cysticercosis or NCC mainly affects lower middle income countries. And in these endemic areas, about 30% of seizure cases can actually be linked to NCC. It's estimated worldwide by the CDC. This is the leading cause of adult onset epilepsy. And about 3 million persons are estimated to suffer from epilepsy due to NCC. Overall, they estimate NCC affecting 50 million people worldwide. So now we know it's more common in those endemic regions, not specifically in the United States, and it can cause epilepsy. So given that, how many hospitalizations, if you had to guess, do you think there are per year in the United States due to NCC? Is it 20, 50, 2,000, or 1,000? And this is just a guess. I will go over the answer on the next slide. Awesome. Okay, good answer. So when I actually first learned about this infection, I thought it would have been something closer to like 20 or 50 hospitalizations, but really it is estimated there are 1,000 new hospitalizations per year in the United States, which can cost up to $100 million per year. It's also estimated that 2% of all emergency department visits for seizures are attributed to NCC. And this is also reported by the CDC to be a potential underestimate. And the reason for that is because NCC is actually not a required reportable disease in all states. The diagnosis is also often not considered by providers, and also members of the high risk group often do have poor access to care. But really the take home point here is cysticercosis. It can affect anyone at any age, even though it is more common in those endemic areas we talked about. It can still be found in non-endemic regions, but more specifically in people who have moved from or traveled to endemic regions. Overall, though, NCC is considered a neglected parasitic infection, or NPI, in the United States. And for those of us who do not know what NPIs are, this is a group of 5 parasitic infections in the United States that have been targeted by the CDC for a few reasons. One being the number of people that can be infected, 2 being the actual severity of the disease, and 3, the ability that we have to prevent and treat it. Overall, NCC really is one of these 5 NPIs, and they are targeted by the CDC for a priority of public health action. Given that, there are some risk factors. The greatest risk factor really is, though, living in close contact with someone who has an active intestinal infection with that adult tapeworm, or the Tinea solium. An infected person with poor hygiene may contaminate food with tapeworm eggs that has shed into their feces, thus transmitting cysticercosis. Another cool tidbit is if you do have that poor tapeworm infection, you can also technically infect yourself, again, through things like poor hygiene. When we're transitioning to talk about the diagnosis, there is no definitive diagnostic criteria. It's really based on what we have on the slide here. So a history, a physical exam, neuroimaging studies, serological testing is also available, and then clinical presentation. But in order to evaluate the clinical presentation of patients, we must understand the stages of NCC. The cysticeri, or the larva, pass through stages which really can be visualized on radiologic imaging. And the staging is so important because it impacts diagnosis, but it also drives the medication management recommendations that we might have as pharmacists. Like we kind of talked about before, after those microscopic eggs of Tinea solium have been ingested by humans, the oncospheres will hatch in the intestine, and then they can pass through the stomach wall, are carried through the blood to the CNS, where they mature in the brain parenchyma. And brain parenchyma meaning the functional tissue in the brain, and it'll then follow the subsequent stages on this slide. So let's break this down a little bit further. The first stage of this is non-cystic. This is the earliest form of larval invasion, where really the embryo is evolving. At this early stage, there will be no changes on CT and MRI imaging for our providers. After the lodged cyst within the brain parenchyma, the larva can become viable or alive, developing into the cysticeri, and this can happen over a few months. So it's estimated around 60 to 70 days, which brings us to the vesicular stage. And this is when the parasite, again, it's alive, it's viable. So on imaging here, we can start to see a difference. Providers can actually see a small nodule, which is the scolex of the parasite, meaning it's the attachment area of the tapeworm. And they can see this projecting into a small cyst containing clear fluid. Usually here, there is no immune response by the host, so there really isn't a lot of edema or swelling going on, but cysts can remain here for months to years, and treatment here is actually considered to be the most effective. But eventually, like I said, it can stay here for up to years, although eventually the cyst will start to degenerate, leading to the non-viable or dying stages called the colloidal and granular stages. Here, that scolex may also still be visible on CT and MRI imaging, but really the main thing to focus on here is this is when we would start to see an immune response from the host being the human. So we'll start to see an inflammatory markers increasing. Once we have that cyst dying, it's going to release pro-inflammatory markers and release antigen, resulting in a lot of symptoms. Treatment here is going to be indicated, but it will be different than the treatment we might have for viable parenchymal lesions, which we will talk about later. And then finally, the last stage is the calcified stage, where the cyst dies. So here we have a parasite that is dead. Therefore, treatment is not indicated. You typically will not have as many symptoms, and there really isn't a huge inflammatory response as well. So overall, breaking down the natural history of NCC, it does include this asymptomatic period that typically lasts several years, followed by a gradual degeneration over a period of at least a year. So given that I just talked about when we have those lesions dying, there's a release of these inflammatory markers. What symptoms do you think these patients would present with then? And again, you should be able to just type within your phone different symptoms. I think you should be able to type in more than one symptom as well. And we will talk about this on the next slide. Feel free to type whatever you might be thinking. Okay. So hopefully this is still working for everyone. Let me see, I have a chat. Okay, so we have fever, elevated creatinine I see in the chat. That's okay, thank you for typing in the chat. Awesome. So main symptoms that we really might be seeing, generally, it's highly variable and very nonspecific. And really it does depend on the number, location, size, and stage of the parasite. But really main symptoms to think about are going to be seizures. So like I talked about before, a lot of patients will be asymptomatic, but it is estimated if patients are symptomatic, up to like 40 to 60% of these patients will have seizures. Also, when we're thinking about those cysts, they can block the flow of fluid generated in the brain, resulting in an increased pressure. And this would lead to causes of symptoms like headache, which can present as well as migraine-like headaches, nausea, dizziness, altered mental status as well. Cysts can block the flow within the eyes as well, and this would lead to symptoms like altered vision or even vision loss. In terms of when would we start to see these symptoms, like I talked about briefly before, there is a prolonged incubation period between infection with NCC and onset of symptoms. So many of the tapeworm carriers who originally transmitted the infection may have cleared the intestinal infection or may no longer even live near the patient that is presenting with symptoms. But overall, most of these symptoms are going to appear again when those cysts start to die, because it will activate our immune system to react against us. And there's this large inflammatory reaction, and it really can occur years after initially being infected. And to sort of kind of back up what I'm saying with this inflammatory response, the 2017 IDSA guidelines have several referrals to looking at the specific inflammatory response. So there was a study that actually looked at the serum blood counts of patients who had neurocysticercosis, and they compared patients who had epilepsy with neurocysticercosis to those that had NCC without epilepsy. And they found that patients that had the epilepsy with NCC had high serum levels of blood-brain barrier breakdown molecules like MMP, which is matrix metalloproteinases, and MMPs regulate aspects of cellular activity with many functions ranging from extracellular matrix degradation, cell proliferation, and even just activation of pro-inflammatory cytokines. So they did also see elevations in things like TNF alpha, interferons, interleukins, increasing expression of lymphocyte adhesion molecules, and also the increased toll-like receptors, which play a crucial role in our innate immune system, and they also increase our pro-inflammatory responses. The next part of the diagnosis is going to be to look at the history and physical exam. So our providers, or if we get the chance to counsel these patients, it's important to ask about, do they have access to safe water and sanitation? And again, when we think about that prolonged incubation period, it's not just asking within, the past few weeks or the past few months, it could be the past few years. And that also goes hand in hand when we're questioning about recent travel to endemic areas. Other types of questions might be, did you recently go to a new restaurant that might not have great sanitation measures and things like that? In terms of imaging, the IDSA 2017 guidelines recommend both CT and MRI imaging. The reason for this is CT is more sensitive for detecting those calcified lesions, so the dead parasite, and then MRI is more sensitive for the detection of the scolex as well as viable lesions. And to visualize what I'm talking about, so on the left-hand side of your screen, you see an image of the viable parenchymal cyst with a scolex. So the circle that you're seeing, those black perfect circles, that would be the cyst, so the fluid. And then inside you can see these white dots, and that's actually the scolage, or the attachment head of the parasite. So treatment here is going to be indicated, and it is going to be different than when we're comparing it to in the middle, the MRI scan of a single enhancing lesion. And then on the right-hand side is actually a CT scan where we're seeing those multiple calcified lesions. But in general, if a scolex is definitively identified, the diagnosis of NCC is certain. So imaging is really kind of considered the gold standard when we're thinking about how to diagnose these patients. And then just as a tidbit, there is a major kind of imaging differential diagnosis that providers might be thinking about. There are a number of infections that can cause imaging that might kind of look like what we see in NCC, particularly tuberculomas. Other parasitic infections can cause changes on imagings as well, brain tumors, as well as abscesses. And then also, just as a tidbit, if we do not have access to CT or imaging of the head, you can see on x-rays calcified lesions. So those white dashes there are actually calcified lesions from cysticercosis. And then the last aspect of diagnosis is serologic testing. So there are two tests that are available. We have the enzyme-linked immunotransfer blot, or the EITB. This is preferred by the CDC. And then the second test is the enzyme-linked immunosorbent assay, or the ELISA test. However, this has a high risk of false negatives and false positives, so it is not preferred. I will say, though, the ELISA test is typically more available in different hospitals, whereas the EITB is not regularly performed. So we might be seeing these patient cases where the ELISA test is performed first, and then it can be confirmed with the EITB test. Okay, so now we know the pathophys, we talked about the diagnosis, and for the rest of the presentation, we're really going to focus on the treatment. So given the fact that I talked about, when we have these cysts dying, you have the increased risk of symptoms, you have these pro-inflammatory markers being released. If you had to guess, which pharmacological categories do you think are utilized in the treatment of NCC? And you can also pick more than one response as well. So is it antibiotics, antiparasitics, opioids, anti-epileptics, prokinetics, or anti-inflammatories? Awesome. Yeah. So we're definitely going to be using antiparasitics and anti-epileptics. We're also going to be utilizing anti-inflammatory markers to reduce the inflammatory response. So that brings us into talking more about treatment. And I just wanted to say all of the treatment regimens that I'm presenting today are from the IDSA 2017 guidelines. There is a lot more in these guidelines that I unfortunately did not have time to present, but this is free access for everyone. So if we ever have other patients presenting with different types of presentations with neurocysticercosis, you can access this online. But really the goals of therapy are going to be to eradicate that infestation to reduce morbidity, prevent complications, as well as prevent subsequent seizures. So I broke this down into 4 treatment managements because, like we talked about before, management really depends on careful staging. The location and characteristics of lesions are essential to determine the best mode of management and treatment. Treatment overall in NCC is considered a complex field, and it must be individualized for each patient. So to start up the conversation, let's talk about viable lesions. Viable lesions can then be broken down even further to parenchymal versus extraparenchymal. So parenchymal, again, being that functional tissue in the brain. Parenchymal is really the most common, occurring in approximately 60% of more patients with NCC, but these patients still might be asymptomatic. If there are symptoms, however, it's what we talked about before that I also have in this table for your reference. Treatment in parenchymal viable lesions is typically kind of short, and the response is usually pretty good. Comparison with extraparenchymal, these patients might require longer treatment. Patients might have a variable response, and the prognosis is not as good with a pretty sizable mortality risk. But the good thing is it is more rare when we're comparing it to parenchymal lesions. We'll focus first on parenchymal viable lesions, thinking about the antiparasitic medication. So before we can even think about verifying orders for antiparasitics or recommending these to our providers, it's important to ensure the providers have done a complete workup, meaning that they have everything we talked about that's required for the diagnosis of NCC, and we have CT and MRI imaging for them to know exactly how many cysts a patient has. And that's because this is really going to drive the treatment recommendations. So if we have a patient with 1 to 2 cysts that are viable intraparenchymal, the recommendation is just going to be monotherapy with albendazole, which is an antiparasitic. If patients have more than 2 cysts, then it's recommended to use dual antiparasitic therapy with albendazole plus praziquantel. Both of these antiparasitic drugs, though, are dosed as mg per kg per day in divided dosing, and the duration really is only 10 to 14 days. However, they recommend repeat MRI testing at 6 months, and if they still see cystic lesions that have persisted, retreatment is recommended. So now you might be wondering, well, why do we need dual therapy if patients have more than 2 cysts? And I found in the IDSA guidelines, this really can be driven by a few trials. One that I want to present for today is by Garcia and colleagues in 2014. They randomized patients in a 1-to-1 fashion to either receive albendazole monotherapy or albendazole plus praziquantel. When they looked at the outcome of resolution of all viable cysts on MRI at 180 days, specifically in patients that had greater than 3 cysts, they found that 68% of patients who received the combination therapy had resolution of all viable cysts, in comparison to only 5% of patients who just received albendazole. And this was statistically significant. So this is really an example of what's driving that recommendation of more than 2 cysts. It's recommended to use dual antiparasitic therapy. More about albendazole. So like I said, it is an antiparasitic. Its mechanism is interesting. It causes degradation of cytoplasmic microtubules, and it also causes a reduction in ATP, decreasing energy depletion and immunomobilization, ultimately leading to worm death. In terms of the pharmacokinetics, it is not well absorbed in the GI system, so it is recommended to counsel to administer this medication with meals, specifically a high-fat meal if possible. It is widely distributed into the CSF, which is awesome when we're thinking about NCC. Some drug interactions to think about. It is a 1A2 and 3A4 substrate, but it is minor. In terms of side effects, these are going to be due to the cytal activity that it has. So again, when we think about when we're killing these parasites, it's going to release that inflammatory response, causing an increase in symptoms that these patients might have originally presented with as well. So things like headaches, seizures, and dizziness. Specific side effects to albendazole are things at the bottom of this slide. So we have hepatotoxicity, bone marrow suppression, and alopecia. That means in terms of monitoring, we're going to want to monitor complete blood counts, liver functions, and seizure activity. It's recommended to utilize this monitoring, especially for using greater than 14 days of albendazole, and the IDSA guidelines do say that weekly testing is reasonable. So that's great. And now you might be wondering, okay, well, when would we recommend to providers to maybe hold therapy based off of these blood counts and liver functions? And that's a great question. So it is recommended to hold albendazole if patients have complete neutropenia or elevation in their liver transaminases. So the IDSA specifically recommends holding albendazole if the levels are greater than 5 times the upper limit of normal. And then Lexicomp in the warning section recommends to hold when it's greater than 2 times the upper limit of normal. But both of these recommend to hold until these laboratory tests normalize. And then once they normalize, considering potential alternative therapy. So should we use praziquantel instead if we aren't already? Does the patient even still need antiparasitic therapy? And then in some cases, we may also retreat with albendazole. But overall, this would be a great opportunity to consult infectious disease and ensure that they're involved with this conversation as well. And then the second antiparasitic medication that can be used is the praziquantel. It is an antiparasitic drug, like I said, but the mechanism is a little bit different. So it's actually going to increase cell permeability to calcium, which, as we know, can cause strong contractions, ultimately leading to paralysis of the worm. It is absorbed a lot better than albendazole, so we don't have to worry about poor absorption. In terms of its distribution, it's distributed less in the CSF, so about 20% of the plasma concentration. It is metabolized by the liver. And the main thing here too is it's a major 3A4 substrate. So we do have an increased risk of drug interactions. So for instance, like our 3A4, CYP3A4 inducers like carbamazepine, phenytoin, phenobarbital, all of those medications can decrease the concentrations of praziquantel, thereby decreasing its effectiveness. And the reason I bring up those CYP3A4 inducers is because if we remember from before, anti-epileptics are going to play a major role in therapy. So it's something to think about when we're trying to choose, what anti-seizure med do we want to recommend? Okay, so next we want to talk about is anti-inflammatories. So this is when we would have our corticosteroids come into play. Corticosteroids are recommended to start 3 to 4 days prior to antiparasitic therapy. And this again is supported because we are anticipating once we start using these antiparasitic drugs, we will have an increase in the inflammatory response, so they can worsen the symptoms. They also have seen from large case series fewer adverse events in patients who were treated with antiparasitic drugs and steroids compared to antiparasitic drugs alone. So based on this fact, most authorities recommend using corticosteroids whenever antiparasitic therapy is planned. There are many side effects that come along with corticosteroid use. So I have a few listed on here just for your reference, but as we know, these side effects increase with long-term duration of corticosteroids, and some of these patients might need long durations. And then dosing, it's not really well defined in the IDSI guidelines, but they do have a chart specifically for viable intraparenchymal cysts, and I have that included on this chart for your reference. So in general, prednisone and dexamethasone are adequate recommendations. We can recommend about 1 to 1.5 mg per kg per day of prednisone in divided dosing. And then specifically for the viable intraparenchymal cyst, the IDSA lists 8 milligrams per day of dexamethasone. When we're thinking about which one should we recommend? I have the dosing equivalents for your reference. So dexamethasone is more potent. It has a higher anti-inflammatory potency. However, there is no mineralocorticoid potency, and it does have a longer half-life. Now, when we're thinking about, well, where did that 8 milligrams per day in divided dosing of dexamethasone come from? The IDSA guidelines also reference the study by Garcia and colleagues on that randomized controlled trial where they looked at patients with viable parenchymal cysts, and they compared 6 milligrams per day of dexamethasone versus 8 milligrams per day for 28 days, and then each were followed by a taper. I have the taper on this slide just for your reference for later as well. They found that there were fewer people with seizures in the higher dose group, so that 8 milligram group, and there were no differences in adverse events. So they saw that at day 10, fewer seizures, and it was statistically significant with a relative risk less than 1. And they also saw this at 21 days. They looked at this even further at 180 days. And when we were thinking about the number of seizure days by 180 days, only 32% of patients who received that higher dose of 8 milligrams per day had seizures, compared to 68% of people who received 6 milligrams per day. And this also was statistically significant. So that's really where this 8 milligram per day recommendation is coming from. Now, the last part about treatment for these viable lesions is going to be anti-epileptics. So this is recommended in all patients who have had seizures prior to starting therapy. The choice really is guided by availability, cost, drug interactions, and potential side effects. So like I talked about before, we do have CYP3A4 inducers when we're thinking about some of our anti-epileptic meds. Like for instance, Keppra or levetiracetam does not have the 3A4 inducer, so that might be a reasonable option in someone who's also getting praziquantel. It is recommended to encourage adherence and compliance because one of our goals, again, is to prevent recurrent seizures. In terms of how long do patients need these anti-epileptics, the IDSA recommends to consider a taper off after 2 consecutive years, and this is specific for patients that have those intraparenchymal viable lesions. If they've had resolution of cystic lesions, so there's no calcifications on follow-up CT, they had few seizures prior to therapy, and less than 2 seizures during their whole course of disease, as well as if they've had no seizures for 24 consecutive months. And we can recommend tapering off within a few weeks after the providers are seeing resolution of those lesions on CT and MRI imaging. Now I wanted to circle back and let's talk about the extraparenchymal cysts. There are many different locations and forms of extraparenchymal cysts, but in terms of time for today, I wanted to focus just on intraventricular and subarachnoid to kind of shed light on how these recommendations we might be making are slightly different. So intraventricular meaning cysts are developing within the ventricles, as we can see on imaging here. The difference for intraventricular is antiparasitic drugs are not routinely recommended in use. Instead, the recommendation here is going to be surgical interventions for potential cyst removal. So consulting neurosurgery to see if it's possible to remove those cysts. Corticosteroids are also recommended to decrease edema. And again, antiparasitic medications are not recommended, nor are they recommended preoperatively, because that again could increase the risk of an inflammatory response, thereby potentially reducing the rates of success in surgical interventions. We also have subarachnoid extraparenchymal lesions. This assists in the space surrounding the brain. Antiparasitics are recommended here. Still, we want to use corticosteroids, but there is also an option for consulting neurosurgery because there is potential for stent surgery if patients have hydrocephalus. Now, there is still more. So there are a few tests that are recommended prior to initiation of therapy. So we want to start those antiparasitics after we start our anti-inflammatory medications with corticosteroids. But before we even do those corticosteroids, it's recommended to screen for strongyloides as well as for latent tuberculosis. As a review for strongyloides, this is a disease caused by a roundworm, and its mode of infection is skin contact with soil that is contaminated with the free-living larva. Patients are typically asymptomatic or they have non-specific symptoms. And how does this relate to NCC? Well, we know with NCC, these patients are going to need corticosteroids that might be long-term. So these infections can be severe and life-threatening in persons who are taking corticosteroids. So this is why it's recommended. And the IDSA says we can actually just start empiric therapy for strongyloides while we're waiting for the results to come back. So if we had providers who wanted to just start empiric therapy for strongyloides, which is a very reasonable recommendation supported by the guidelines, what medication, if you know, would be used for this? Is it praziquantel, hydroxychloroquine, erythromycin, or ivermectin? Okay, great. So the answer here is actually ivermectin, and this is typically dosed at like 200 mics per kilo per day for really only 1 to 2 doses. So oftentimes we might just be giving a few doses of ivermectin before we even have results for the strongyloides test, and that is a reasonable and recommended option. For latent tuberculosis, the reason is also similar. So this is because you do have a risk of tuberculosis reactivation with use of high-dose corticosteroids, and they can also suppress the reactivity of the test. So it is recommended to test for latent tuberculosis before we even start those corticosteroids. So now we'll finish this presentation talking about the last few parts of treatment management, starting off with enhancing lesions. So again, this would be an MRI image of a single enhancing lesion. And the differences in therapy recommendations is it's recommended to use monotherapy antiparasitic drugs with albendazole, again in the mg per kg per day dosing and divided doses, and the duration is in 1 to 2 weeks. Anti-inflammatories with corticosteroids are still recommended to be given prior to as well as during antiparasitic therapy. And then same thing, anti-epileptics are recommended in patients who have had seizures. This duration, though, is a little bit less for single enhancing lesions, so we can consider a taper off after 6 consecutive months. If patients are seizure free, we see resolution of lesions on imaging, and there are no risk for recurrent seizures. Patients who are at higher risk for recurrent seizures, that would be having like calcifications on follow-up CT, breakthrough seizures, or seizures during the course of disease. And then calcified parenchymal lesions here, as we remember from before, the parasite is dead. So there is no indication for antiparasitic therapy or anti-inflammatory therapy. Antiepileptics are still recommended though in all patients who have had seizures. And then lastly, we have patients that have the cerebral edema. Antiparasitic therapy is not recommended here because we have that inflammatory response already. We do not want to worsen those symptoms and put these patients at risk. So really the core therapy here is going to be corticosteroids for that diffuse cerebral edema, and then antiepileptics as needed. And this actually is a more common presentation than you might think. It is estimated that approximately 20% of cases present with increased intracranial pressure having this hydrocephalus and cerebral edema. And then just circling back to our conversation about corticosteroids before. So we talked about the recommendations, how they're not fairly consistent, but I just wanted to draw our attention to if patients have those ventricular extraparenchymal lesions, we could be seeing orders for doses of dexamethasone up to 24 milligrams per day. So it is a reasonable option for patients that have more of an extraparenchymal lesion that puts these patients at risk for a greater inflammatory response and a reduced response to treatment. And then again, here is just the table about our corticosteroid recommendations with the dosings listed. And that really ties up our treatment. I just wanted to briefly go through like a wrap up of what I talked about. So again, viable lesions, intraparenchymal viable lesions, we're going to see these three core drugs of steroids, antiparasitics, and antiepileptics. For enhancing lesions, it's the same except monotherapy of albendazole is recommended. For calcified lesions, there is no indication for an antiparasitic or anti-inflammatory medication because there is no active viable lesion or there's no dying lesion. And then cerebral edema, the core is really going to be steroids to reduce that inflammatory response and hopefully improve patients' symptoms if they have any. Now, just for conversational purposes, I wanted to do a cost comparison. So if we were giving a 1 month supply of these medications, what medication do you think costs the most? We have A as Venclexta, B as vincristine, and both of these medications can be used in leukemias. 3 for C, we have cefiderocol or Fetroja, which is a new antibacterial. And then D being albendazole, what we use for patients with NCC. If you had to guess, which medication do you think costs the most? Okay, great. Yes, so actually, albendazole costs the most out of all of these. So I did this calculation based off of the LexiComp prices that are listed with a typical 30-month supply. I do want to make a note that Venclexta actually costs a little bit more than this. So the $83 is just the initial ramp up for AML. But after a 1 month supply, it still would be around, a couple grand, whereas albendazole can cost up to 40 grand. I would also like to mention that in our cardinal system, albendazole is a little bit cheaper than what's listed on our LexiComp pricing. However, this medication is only available as 200 milligram tablets with 2 tablets per bottle. And the reason for that is because a lot of other infections, you may only need to give like 400 milligrams times 1 or 2 doses. So that's really why it's available by the manufacturer like that. But in patients with NCC, we're going to be using a lot more than like 400 milligrams per day of albendazole. For instance, the patient that I had, we gave like a gram of albendazole a day. It was about like 5 to 6 tablets. So we needed to order a lot of bottles just for 1 day of therapy for this patient. And then to end the presentation today, given all that information, do you think albendazole is on our formulary at Stony Brook? Yes, so it's actually not available on formulary, but it is something that we can order with a non-formulary request. Okay. And then just to end the conversation for today, we'll circle back to that patient case. So again, this patient was diagnosed with neurocysticercosis. So you can type in the chat or feel free to unmute yourself. but we'll walk through this. So if we had this patient, would you like to test for tuberculosis and strongyloides? Just yes or no? Yes. Awesome. So we do want to test for strongyloides and tuberculosis, which is what we did for this patient. Our TB was negative, and again, which is a supported recommendation, we started the patient on empiric ivermectin for 2 doses, and then we discontinued therapy afterwards, but they did have a negative strongyloides IgG. In terms of serological testing, do you guys want to do that testing? And if you do you prefer an EITB or an ELISA test? Yeah, so ELISA is the one that we do have more easily performed at the hospital, but it is has poor sensitivity and specificity. So it's not preferred by the CDC. And we actually did the ELISA test for this patient, and the IgG was negative. But then when we communicated with the CDC for EITB testing, that came back positive. In terms of anti-inflammatories, the medical team started prednisone at 1 mg per kg per day, which is an adequate recommendation. Now going into antiparasitics. So this patient specifically had more than 2 viable cysts in the cerebellar hemisphere, the right occipital lobe. There was a definitive scolex seen, so we knew this patient had NCC, and there was diffuse cerebral edema. So I guess my first question is, do you want to start antiparasitics, yes or no? And then to follow up with that, do you want to start these antiparasitics before or after anti-inflammatories? Yeah, so we do want to start antiparasitics, and we do want to start this medication after corticosteroids have been on for 3 to 4 days, because again, we're anticipating this inflammatory response when we start these antiparasitic medications. So for safety for the patient, we want to hold the antiparasitic treatment until we have a few days of anti-inflammatories. So this is something that our medical team did not know. So they actually started albendazole with the steroids on day 1. When our ID team was consulted, they recommended to DC albendazole until that workup was completed. And I think this is something cool for us as pharmacists to know, because since it's not on formulary, if we ever have pressing matters to get this approved and ordered, we can ensure that they have started corticosteroids and have it on for a few days. So we don't need to necessarily worry right about getting these medications as soon as possible, but they are needed just after a few days. Specifically, this patient, it's a little bit more in the gray area. So these cysts were in the cerebellar hemisphere. So thinking about, okay, is that parenchymal or extra parenchymal viable cysts? That was the question at hand. They actually had a conversation in the ID conference, as well as consulted different providers from different hospitals. And this is a very rare form type of NCC, and it needs to be treated a lot more differently than what we would think. So you need 2 antiparasitics because there were more than 2 cysts, but the treatment needed to be very long. So 2 to 3 months of therapy was needed, and we needed to do a very, very slow taper of steroids when we finished them. And the reason for that is because this could technically be considered an extra parenchymal lesions. And then lastly, the question is, does this patient need an anti-epileptic? This patient did not have any confirmed seizures before we started treatment. So yes or no to anti-epileptics. And really there is really no right or wrong answer. Technically, you don't need it since we had no history to seizures. We didn't really know the events leading up to the syncopal episode. However, neurology was consulted, and they did recommend starting Keppra 750 BID for prophylaxis, which is reasonable given we didn't know the entire picture. It's going to cause probably minimal harm to the patient. And once we did start it, there was no safety concerns. And this patient, we were actually able to prevent recurrent seizures or new seizures as well. So that confirms this case. Thank you all for your participation. Here are some additional references that I didn't have opportunities to include. And thank you. If there's any questions, feel free to unmute yourself or type in the chat. But once again, thank you so much for your time and for participating throughout this presentation.